I work in women's health, and particularly in osteoporosis and in estrogen-sensitive breast cancers. We just completed a phase 3 trial with an exploratory or investigational drug called abaloparatide. We had over 2,500 women in the trial, and they were randomized to placebo, teriparatide, or abaloparatide. After following the women for 18 months, we found out that in both the teriparatide and the abaloparatide arms, there was an increase in bone mineral density. There was a little bit more increase in bone density with the abaloparatide group in sites that are rich in cortical bone, like the total hip and the femoral neck. We also found that there was a reduction in fractures. There was a reduction in new vertebral fracture in both the abaloparatide and the teriparatide arm, 86% reduction in the abaloparatide arm and 80% reduction in the teriparatide arm. When we looked at non-vertebral fractures, we found a little bit of a difference. For abaloparatide treated women, there was a 43% reduction in non-vertebral fractures compared to placebo. In the teriparatide arm, there was no significant difference compared to placebo. When we looked at another fracture category, major osteoporotic fractures, those are fractures of the clinical spine, hip, shoulder, or wrist. We found that abaloparatide reduced fractures compared to placebo and compared to teriparatide. We've also discovered that abaloparatide works across a wide variety of women with baseline risk factors. For example, across different ages, across whether you've had a fracture or not, whether you've had a vertebral fracture or not, the drug works equally well. So this opens up a new anabolic agent or bone building agent for a wide variety of women with postmenopausal osteoporosis. The most interesting thing we found in the phase 3 trial is that because this was a broader population of patients than the trial that was originally done with teriparatide, teriparatide didn't work quite as well as we anticipated. So teriparatide worked very well in a group of patients that were at very high risk and had 2 or more vertebral fractures. But in this broader population, we found that abaloparatide effectively reduced vertebral, non-vertebral, major osteoporotic fractures, and actually clinical fractures as well. Well, worldwide, there are like 7 to 8 million fractures a year, and in the US alone, there's 2 million fractures per year. The healthcare costs in the United States run between $17 and $20 billion a year just because of osteoporosis. And there are more days of hospitalization due to fractures than there are days of hospitalization due to breast cancer, diabetes, or myocardial infarction. So if we can prevent those fractures, we will actually be able to not only help our patients and reduce disabilities, we'll also be able to reduce healthcare costs and hospital utilization. So in the phase 3 study, the primary endpoint was the reduction of new vertebral fractures. There were a number of secondary endpoints, which included the reduction in non-vertebral fractures, the increase in BMD at the lumbar spine, total hip, and femoral neck compared to placebo, and a large number of other analyses that included looking at the fracture risk reduction from major osteoporotic fractures and clinical fractures. Well, we're looking at different ways to treat patients with osteoporosis now. One of the things we're talking about is treatment to goal. You set a goal for the patient, just the way you would set a goal for hypertension or diabetes, and try to reach that goal. Most of the drugs on the market, the anti-resorptives, just maintain the bone. They increase mineralization, so there'll be some changes in bone mineral density, but they don't really build new bone. To reach the treatment to goal, to reach the goal you set, you may actually need to start with an anabolic agent. So this drug, hopefully, if approved, would be able to fulfill that role. So there are many treatment options for postmenopausal women. The largest category are the antiresorptives. The antiresorptives actually reduce the osteoblast activity in number so that bone cannot be resorbed. Those include the bisphosphonates, denosumab, things like that, and estrogens would be in that category. Raloxifene, the SERMs. The other category would be those that actually build new bone, and that includes teriparatide and, if approved, abaloparatide. Again, if you're trying to actually increase bone, most people start with the antiresorptive agents. But if you really want to build new bone, it may be better to start with an anabolic and then maintain that bone with an antiresorptive agent. Well, we'd like to study the drug in other patient populations so that we could actually help men with osteoporosis or patients who are on glucocorticoids, for example, and have rapid bone loss. There are other subpopulations that are of an unmet need. Men with prostate cancer who get on hormone ablation therapy, or women with breast cancer who are on estrogen deprivation therapy all lose bone very rapidly. So we'd like to help a large variety of patients. I think one really important thing to understand about osteoporosis is we're often focused on the hip fracture. The hip fracture does cause a lot of disability and cost, but it's really unfortunate that 50% of patients who've had a hip fracture had a prior fragility fracture. So if we actually captured patients earlier in the course of the disease, when they had that first fracture, we actually may prevent that costly hip fracture that happens much later in life.